Welcome back again. Nice to see you. And now we start the first of our panel discussions. And our first one is going to look at why ethics should be a key focus of healthcare improvement. When people talk about quality improvement, what they mean is ways of improving processes to deliver high quality, safe healthcare. But actually, some of the biggest dilemmas and most intractable challenges are the ethical ones. Things like how choices are made about which aspects of care to improve and for whom, whose definition of what counts should prevail, the quality of the evidence, issues of equity and access, who bears the opportunity cost of change, and all the ethics of decision making in times of limited resource, which is to say, all the time. And I want to welcome our four panelists, Dr. Zoe Fritz, Dr. Yasmin Gunaratnam, Natalie Richards, and Tim Stevens. And can I ask each of you to introduce yourselves, starting with Zoe. Hello, Zoe.
Hello, hi. My name is Zoe Fritz. I'm a consultant in acute medicine at Cambridge and a Wellcome Fellow in Society and Ethics. And I conduct what I call empirical ethics research. So analysing problems, trying to develop alternatives, ethical problems, trying to develop alternatives, and then applying empirical methodology to evaluate them.
Fab. Yasmin.
Hi everyone, I'm Yasmin Gunaratnam and I work in the Sociology department at Goldsmiths, and I do very small scale research, so ethnography, which means being in a setting for some time, and also one of the methods I use is narrative medicine. So I'm really interested in ethics as a process and a relationship.
Natalie.
Hi everyone, I'm Natalie and I'm a research assistant at this institute, and I'm currently working on a project that looks at access to secondary mental health services during the COVID pandemic. So that's me.
Thank you. And last but not least, Tim.
Hi, my name is Tim Stevens. So I'm a critical care nurse by background, but also a mixed methods researcher. I'm based at Barts Health NHS Trust and Queen Mary University of London. And like to think of myself, I guess, now as an improvement scientist as well. And what I'm particularly interested in is how complex interventions, such as quality improvement interventions, how they actually work, at the front line, and sort of particularly within the spheres of acute care and sort of how patient care can be improved around the time of surgery.
We like people who think of themselves as improvement scientists. So I first of all have to say to the audience, we want you to be part of this discussion as well, which of course can continue on the forum afterwards. But if you've got particular questions you want to pose, then please do send them through Slido and I'll ask them. So I want to start with asking you all, is it possible to determine what the right thing to do is, and how can we define the right thing? Let's start with you, Tim.
Gosh, okay. So, I mean, I think some of that is about the scale and scope, isn't it? So, what's the right thing to do for a team, in a hospital or department? You do an audit, maybe you identify a quality problem, or you have feedback, or you're just aware that there's a problem with the process. Then, that's why I think clinician-led quality improvement is so important, because you're experiencing, you're living a problem, and therefore, you want to fix it. I think when you sort of zoom out and figure out what you want to fix at a sort of regional or national level, and obviously that gets a bit more tricky. So, well, what, of all the many things you could focus on, what do you select? I worked with the Royal College of Surgeons a few years ago and ran a quality improvement program called Cody Quick, and the RCS canvassed its membership and said, what should we focus on for our first quality improvement program? And they got a few ideas back, but overall, people said we focus on gallbladder disease. That's a key thing that we know is a big problem. And even the non-general surgeons agreed, yes, this is a problem that needs to be fixed. So I guess canvassing the opinion of clinicians, patients, people who it matters to is probably the best way that I know of to figure out what to focus on.
Zoe, what are your thoughts on this?
Well, I'll add to Tim. So absolutely getting an idea of not just what is the right thing to do for one group, but what is the right thing to do for all of the stakeholders. So Tim's talking about canvassing across the surgeons, but then I think we would also say, well, we need to look at patients, we need to look at nurses, we need to look across the organization. So there are sometimes you can say something is empirically right to do. We know that if an antibiotic cures someone from pneumonia, it is the right thing to do to give them that disease. We always, that antibiotic, but we always then look, for example, at side effects of the antibiotic. And in the same way, in organizational change, in order to determine what is the right thing to do, we need to look at what impact it has to all stakeholders, and then we need to look at unintended effects. So you mentioned opportunity costs. So there's not a neat formula, but I think a first stab would be make sure you consider all stakeholders and look at unintended effects.
Yeah, and how do you make sure that you're getting everybody's interests? Natalie, what about you? Because in mental health, you've got to make sure that service users' views are involved. How do you ensure that their voice is as loud as the service providers?
Yeah, it's a good question. I guess in our study, we, as you mentioned, we spoke to service users and carers and staff. And I think it's just acknowledging that you do need to speak to these people and you really need to tease out the issues that are important to them. And I think that kind of leads into it relates back to the previously answered about because I think it really does depend on what the service user or the carer or the member of staff want in that situation.
Yasmin, what's your take on this? As you're in the situation, you are one of those people who are right in the middle of these conversations.
Yeah, I mean, I think the only answer to your question of what is good ethics has to be it depends. I think context is really important, and also the fact we need to recognise that healthcare and healthcare improvement takes place outside of institutions. So lots of care is delivered in the home and in community settings. And so I think we have to be aware of what I've been thinking of as an ethical parochialism, where the big studies and the big, the big data sets dominate. So for me, I think particularly in terms of how matters of bioethics have really shifted, it's really important to think about ethics as a relationship.
That's a very interesting term, ethics parochialism. It's not one that I've come across before. You're laughing there, Tim. Is that something that you've come across?
No, I just think that those of us who work in the hospital settings think that everything revolves around us to some extent until we stop and remember. Actually, it's as Yasmin said, it's what happens in the community and primary care that really drives everything, and we're kind of the end of the path in many ways. I just wanted to say about deciding what's the right thing to try and fix. From a more technocratic point of view, or sort of improvement science point of view, it's not just a topic, but I think also we need to get better at figuring out what can be fixed through quality improvement. Not all problems can be fixed that way, although I think there's been a lot of desire to fix all kinds of problems with quality improvement that perhaps are never amenable to that methodology. And I think we need to get smarter in this next decade at choosing problems that can be fixed through quality improvement, and improvements that can't be, money problems, need to be fixed through financial and policy issues instead.
And how do we apply an ethical filter to the decisions about which problems should be top of the list? Zoe.
So I think this comes back to looking at what are considered to be the greatest problems, and not just right this moment, but what problems we can project for the future. So we have to be careful not to be reacting just to what there is, but make sure that we're looking at what problems we might be creating for an unsustainable future healthcare. So my own view is that we need to consider, as you said, an ethical filter. I think there are 4 principles that we've derived from looking at rules and SCAN and various others, which are essentially you need to be looking at policies which might not be equitable, policies which might not be sustainable, policies which might not be transparent, and policies which disadvantage those that need the advantage most in a way. So that's a kind of an added on to the equitable. And I think if you identify problems in those areas, then they need fixing. So if I very briefly say, one of the examples that I've worked on was looking at do not resuscitate orders and saying the way that these were discussed was causing poor experience to patients. And it was the way that they were being interpreted was causing inequity, because patients were getting different treatments if they had a DNA CPR than if they didn't. So we saw a moral problem, we saw an ethical problem. I think one of the other ways of highlighting them is if it causes moral discomfort to clinicians, then that's a problem. If it's causing poor patient experience, then that's a problem. So to repeat, I think there are 4 principles, but actually there are triggers that will make you then say, is this a major ethical problem? And those would be poor patient experience, moral discomfort of clinicians. I'm aware I need to keep quick, so I'll finish there.
But
come back to me later.
That's very interesting, but it also brings into mind who you should consult. So for instance, should you be consulting in that particular situation relatives, because relatives may have rather different views to the patient, and you know, whose view prevails?
Is that back to me? Is that
yeah,
okay?
Back to you though.
So
anything else that have
I know, I'm happy to keep going. I think there is a significant degree of consensus building that has to happen. So as I say, I think identifying the problems often comes from either the clinicians or the patients, but they can come from the relatives. But then as you go on to investigate this problem, so I'll just stick with resuscitation as an example. So we then did absolutely talk to relatives, talk to nurses who were really uncomfortable that when patients had a DNA CPR, they didn't feel they had the agency to be able to phone a doctor in the middle of the night. So that was another problem that was identified. And then problems with transfer into the community. So you identify a problem that's causing moral discomfort or distress to patients. You identify how it's ethically inappropriate, either because it's not being equitable or whatever else. And then you look at all of those different actors in the area, so all of the different stakeholders, and you say, what are the problems and what are your ideas on how we can fix this? And then the next step is to try and develop a way to fix it, and then to test it, and then to go back to all of those different actors. But the identifying the problem and identifying the stakeholders are 2 critical steps.
Thank you. I've got a question here that's come in from Catriona Cox. To what extent do you feel traditional ethical frameworks or philosophical traditions can be useful in guiding healthcare improvement? Yasmin, can I turn to you for that?
Yeah, I also just wanted to say I made up the term ethical parochialism. So
you heard it here first, everybody. Ethical parochialism, I think it's an exceptionally useful term already.
Can you just repeat the last part of that question?
Yeah, so to what extent do you feel traditional ethical frameworks or philosophical traditions can be useful in guiding healthcare improvement?
Yeah, I'm really glad about that question, because I've been thinking about different sort of philosophical approaches, but also what's been happening, I guess, thinking about the coronavirus pandemic at the moment. And for me, the traditional ethical principles of, do no harm, beneficence, have really been reconfigured in the pandemic. And I've been noticing, for example, what's really emerging as important is connecting the different levels. So the personal, the local, the national, and the global. And so, in thinking about how philosophy can inform those sorts of different levels, I think there's different philosophers who address that. But I think what's really important is addressing now. So we've been so happy, or the government's been so happy about the Oxford vaccine. And I think the Lancet's been producing some really interesting articles on vaccine nationalism. So to be thinking about how the virus, we all know we're interdependent, but a few countries have been pre-buying through what's called advanced purchase agreements, billions of doses of the vaccines. So I think philosophers, in helping us to think across levels and reframe ethics, is going to be really important at this time.
Yes, that's a point very well made. Here's another question from Francesca Dakin. How do we make processes of change more friendly to ethically motivated interventions? Who wants to take that? Tim.
Yeah, I wonder what an ethically motivated intervention, what that means exactly. Well, so I suppose one of the things we need to make them more friendly, well, would be the stakeholder engagement. I think, sort of going on what Zoe was saying, sometimes a problem is identified by a group, whether that's a clinical group or patient group, but actually the solutions, need to come from a wider group of people, don't they? And I guess if you want to make whichever setting, an intervention that's friendly and going to be feasible to use, it needs to address the needs of and come from the ideas and be acceptable to as many of the stakeholders as possible. So I think, yeah.
There's a question here, which I think actually is one for you, Natalie, an interesting one from Jane Dunnage, and quite a lot of other people have liked this question. If we continue to work on patient involvement, will some aspects of ethics be devolved to them rather than an anonymous committee speaking on behalf of the public?
Yeah, I think that's a really good question, and yeah, I think so. I think if we can continue to involve people at every single level, so for example, in a research project, if you're thinking about the aims of the project, checking that with people, making sure that that is what these people, would benefit from. I think it's really powerful to have that involvement throughout every single stage, and just going back to people and sense checking, is this what is helpful for you? Is this what you need? And I think, yeah, that does place a lot of power with the service users or the carers or whoever it is that you're consulting with.
So actually that involvement should be there ahead of developing your project, shouldn't it? Because, you want to find out what it is about, some particular thing that affects patients' lives that they feel is top of their agenda rather than what's top of your agenda.
Absolutely. Yeah, I think so. I think that before a project starts, you should look at it with an ethical kind of lens and just think, what is it that we're trying to do here? Who's this going to benefit? Are there any unintended consequences, and how can we mitigate them? So, yeah.
Now, this is a question for all four of you, and you may groan. I just warn you now. So somebody sent in a question. I suspect that when some researchers hear the words ethics, their hearts sink. And they focus on the bureaucratic issues of ethical approval, and haven't we all seen that? Is there a way for research on ethics to play a positive facilitating role in improvement science instead of a restraining one? Who wants to tackle that first? Zoe?
So I do think there needs to be a distinction between research ethics and ethical research. And I wonder whether in that question they've been conflated a bit. So I have suffered in getting ethics approvals for my research into ethical behaviors as much as everyone else. And I know that Mary and everyone at this is keen to try and help improve the structures so that we can get quicker, ability to proceed with research that will improve patient experience, perhaps, or clinical experience, or get towards the right thing to do without it taking 6 months to get permission to interview 20 people. And that the constraints on making sure that research is following ethical guidelines have just been transferred from clinical trials to ethnography and everything else without much thought as to what the negative impacts can be. So, I think there is probably a whole strand of saying that, in fact, the strand of research that could be done to say that research ethics is actually thwarting ethical research. And I think that's a discussion that could be had.
I hope there's a discussion that will be had, actually, because it's very important to have it. Tim, how about you?
Yeah, completely agree that at the moment the research ethics framework, although it has got better for NHS sort of ethical approval, is still somewhat unsuited to doing mixed methods and qualitative research, which often you do need to do either by itself or alongside the quantitative research and the trials into sort of quality improvement research. And people think that because you're not doing a trial, that it's some sort of witchcraft that you're trying to enact on people. But I think, on the issue then of the sort of philosophical side of ethics, I think if you do quality improvement well, in terms of you're carefully selecting the right issue, you're engaging with all the stakeholders in a meaningful way, then I think maybe we don't necessarily think about that as an ethical process, because you're thinking about doing good improvement. But actually, I think they kind of, there's a massive overlap there between those two things, and it would be useful, I think, for ethics research to maybe highlight a bit more that improvement scientists, if they do good quality improvement, are doing good ethical work at the same time. Well, the ethics of that is good at the same time.
And who would you look to change the frameworks that are around at the moment in order to make it easier, and to really for people to see improvement science and ethical issues in a different light from perhaps they are at the moment? And that's to you again, Tim. I'm sorry.
Oh, to me again. Okay, point.
Yes.
So things are getting better. I feel like there's I don't know what Yasmin thinks, but I feel like there's a kind of slow sort of glacial sort of drift towards things getting better in the recognition. I suppose we probably just need to sort of petition the people at the HRA and the people who are going to manage that system that is the research, the ethics governance system, to have that recognition and of different study types and how they all sort of feed into the science.
And to streamline those study types.
Huh?
To have some better filter questions that allows you to streamline different study types. Yeah.
So I think that means that that you should, perhaps this institute should ambush the HRA, get them all in, not let them out until they've sorted things out. Yasmin.
Yeah, I wanted to say something just about the ethical research aspect particularly, and there's a reverberation for me so I always have a big sigh when I've got to do an ethics proposal for a committee. I think we all kind of recognise that, but it actually does help you to think yourself into a project and a situation, which is actually very helpful. But then there's also to come back to philosophy and thinking about continental philosophy. I think what ethics does is to try and force us into this false position of mastering every surprise in advance. And we know that in responding to difference and otherness, so again, this is from continental philosophy, is that we have to be open to surprises. And so I think you have to manage these two times of doing the work of making sure your processes are ethically sound in that way, but also being open to what happens when you're doing the research. And I think that's the tension for me.
Natalie, how would you deal with people who see ethics as something that's a heart sink rather than giving joy?
Funny question. I agree with Yasmin, I guess. I think it can be a time consuming process, and you can sigh sometimes, but I think it does kind of put you in the mindset of and guide you on what you need to think about, at least. Well, it definitely does for me as a research assistant. I think it's useful to help you to guide your thinking, and I think you have to be careful not to be tokenistic as a result of the kind of requirements. So I guess that's a bit of a frustration, but I think for me it's a helpful guideline. I don't feel as though I could say anything else.
Thank you. So I think there's an interesting question here, which is, do you think that there can be too much importance placed on individual autonomy in ethical decision making in modern medicine? If so, does this reflect the individualistic Western culture we live in, and can it cause tensions when working with different cultural groups? Who wants to take that? Yasmin.
Yeah, I was involved in a study some years ago with Macmillan Cancer Relief called the Listening Study. And we were looking at patients' involvement in cancer research, clinical trials. And what we found out from that was that particularly Black and racially minoritized groups were often excluded from clinical trials. So we did a follow-up study, particularly with those groups. And it was really interesting around consent, because they said consent is very individualized. And when they're making decisions, you know, they want to involve their whole family, ring the family up in Pakistan or wherever it was. And so I think this individualism and the focus on autonomy can really, I think it's ethnocentric.
Yes, because so in some cultures, you know, there's a patriarch who will take decisions on behalf of the entire family, and perhaps we're not recognizing that. What about in mental health, Natalie? Is there a particular issue there? And there's another question that actually rather comes into this, which is, sorry, I've just lost it for a second. Yes, how are you involving wider cultures using services?
Sorry, could you repeat the first half of the question?
So it's how, you know, again, this is a similar things. Are ethics based on Christian Western values? How do we reflect wider cultures using services?
Yeah, I think how we specifically as a research team are addressing that is to try and reach out to specific groups. So for example, there's Black Thrive and other kind of organisations that specifically look at mental health within certain groups of demographic groups, because we just felt that it was really important to target, kind of send out targeted invitations. In terms of the first half of the question, which I'm forgetting once again, about ethics, I think, yeah, ethics definitely has a sorry, I forgot the question. Please repeat.
No, don't worry a bit. So another question, which I think is a very interesting one, which is there are interesting points on the ethical tensions between views of clinicians, patients, and family members. Is this even more the case with children, young people, and other groups perceived to be particularly vulnerable? I'm going to ask you, Zoe, that. Do you come across that a lot in clinical practice?
I don't much. Can I just say something else on autonomy, or do you want me to? Yeah. So because I think that's the idea that we're the kind of primacy of individual autonomy, which has kind of come out in the last, I guess, 20 years, I think is being challenged. And I think that's one of the problems with applying an ethical framework that everyone then goes to a tick box, is they're always thinking, is this respecting the individual's autonomy? And of course, autonomy is important. But I think it has maybe forced us, it has taken over us thinking about other things. And it just brings into sharp relief this idea of having to get a balance between those things. Perhaps an example of this is the idea that we need to have shared decision making instead of saying we need to have shared understanding. And actually the clinician has a responsibility to give some kind of guide on what would be needed. And I think that's particularly important across cultures where perhaps some people want that guide more than others. I'm sorry, I don't do any pediatrics, so I don't feel.
All right, okay. So this is our final question, and I want to throw it to all of you. Very brief answer. I'm going to give you my well-known Vivian Parry magic wand. And I want to ask you, what one thing would you like to see done in order to ensure that ethics is an integral part of improvement research? Yasmin.
I think for me, it is recognising that health improvement goes on in different settings and involving particularly patients and their loved ones in that process.
Natalie.
I think for me, it's using the voices of the people at the heart of the issue, and just not assuming that you know what the issues are from the back, finding that from the ground and working on that.
Tim.
Yeah, I think we know more about what works now in quality improvement, but resources are finite, time and energy, money are finite. So picking both the right problems carefully and problems that can be fixed in quality improvement. I think we need to do more of that upfront consideration to make sure we're using our time and resources wisely to fix the problems that can help the most people.
Zoe.
Repeating it a bit, but I think it's wide stakeholder involvement to identify the right questions, and then again to address whether you have the right solution and what possible unintended consequences you might have created.
Excellent. Thank you all so much. Very good discussion. And the discussion, of course, continues. You can go through to the forum, and I hope that all of you will be part of that discussion. And ethics, it's got to be part of the solution.